Hello, and thank you for joining me today on this talk on mechanical ventilation management. My name is Ray Luna. I'm an adult gerontology primary care nurse practitioner and a adult gerontology acute care nurse practitioner student. And myself and Gabriel worked on this project together. And thank you to Dr. Blackwell for giving us the case study. So our case study is a patient's been admitted to the ICU with severe necrotizing pancreatitis. A few hours after admission, he went into respiratory failure and he was intubated. Initially, his oxygen saturation had improved after intubation to 90% range on an FiO2 of 50%, but in the past couple hours, the nurses had to increase the FiO2 up to 70%, and his SaO2 is still in the lower 90% range. The patient remains on a PEEP of 5, and nurse drew an ABG, which showed a pH of 7.35, PCO2 of 38, PO2 of 60, and a bicarb of 22, and that was on a FiO2 of 80%. The patient's chest x-ray, it's going to be on the next slide, but we just wanted to mention that an echocardiogram was done earlier in the day and it revealed a normal left ventricular function. So this is the patient's chest x-ray. As you could see, completely whited out. Definitely not a good sign to us. We believe we have a diagnosis of severe ARDS. And again, you can see on this slide here, just to recap what the patient's ABG was. So the first question is, how do you explain his worsening oxygenation status? To us, again, it appears that the patient may have developed severe ARDS based on all the symptoms and the clinical findings. And just to reiterate, acute respiratory distress syndrome, according to the definitions that exist out there, is a reduction in lung compliance, increased shunt fraction, and dead space ventilation. And of course, a chest x-ray depicting the bilateral infiltrates with a normal cardiac silhouette. And this is also important here, a PaO2 and FiO2 ratio less than 300. And a PEEP greater than 5 by the Berlin definition. Essentially, it's a refractory hypoxemia. So what can we do to improve this patient's oxygenation? Well, the first priority, as with any patient, is to treat the underlying cause, right? So we have a diagnosis of necrotizing pancreatitis. So we're going to make sure that we consult infectious disease. We're going to treat the infection, put the patient on broad spectrum antibiotics until the appropriate cultures come back. And as far as lung protective ventilatory support strategy, we're going to, be using PEEP according to the ARDS network protocol. And we're going to try to do low tidal volume, and we're going to start off, the range is 4 to 6 mils per kg of ideal body weight. That's very important. But we're going to start off on the lower side, on the 4, just to make sure that, we don't cause any lung trauma. And then we'll slowly and gradually increase the FiO2 up to 1 and a PEEP up to 20, so we can prevent ventilator-induced lung injury. So what other changes should we consider in the vent settings? Well, we can consider a different mode. We can try airway pressure release ventilation, or APRV. APRV has been shown to improve gas exchange, reduce the need for sedation and paralysis, and increase cardiac index and urine output, which we know in these critical care patients, a lot of times, you're dealing with multi-system situations, and we want to do as much as we can to decrease the work of the heart, and then of course using as little medications as possible, because we know that long-term sedation and paralysis can cause some other untoward effects. We can also try pressure-controlled ventilation. If it's difficult to maintain low pressures with volume control, this will allow for safe pressures to be set and tidal volume delivery monitored and optimized in individualized patients. We can also try high frequency oscillatory ventilation, or HFOV. Just wanted to put a note in here that even though the HFOV has been shown to be safe and effective and an alternative to pressure control ventilation in random controlled trials, it has not been clearly demonstrated that it's superior and improves overall survival. Another thing we can try is permissive hypercapnia. It's also been shown to be effective. Sorry, that's an error in that slide there. In studies with ARDS, it is a deliberate limitation of ventilatory support to avoid lung overdistension and injury. Just some numbers in there. We want to make sure that we keep all of our parameters in check, just to prevent volutrauma, barotrauma, atelectrauma, and biotrauma. And last question is, if his oxygen saturation fails to improve despite being on high levels of support, in other words, the FiO2 of 100%, PEEP of 20, what other options do we have for improving his oxygenation? Well, we can try prone positioning. There's a couple different ways that we can do this. We can there's specialized beds that help us with prone positioning. Of course, we can just do manual positioning and turn the patient over. Of course, this includes, we have to have a lot of more manpower involved in that and have the staff that's comfortable with those kind of techniques. It's not every day that you have this kind of team and manpower that are familiar and comfortable with these types of things. We can try neuromuscular blocking agents. We know that if the patient's unable to increase get their oxygenation better on their own, and they might be working hard, we might have to paralyze them. Of course, we can also try ECMO, and that's another thing that is not offered at every facility. There's only certain facilities that offer that. So it may be difficult to find a place that is capable of doing ECMO. And then lastly, we can do some other recruitment maneuvers like inhaled pulmonary vasodilators, surfactant replacement therapy, anti-inflammatory therapies like high-dose steroids and prostaglandins, etc. And just once again, we wanted to point out that the efficacy of some of these techniques, they remain under study, and they've not been proven to improve overall outcomes in ARDS. So therefore, we have to be careful, and we have to, as with anything, weigh the risk versus benefit, and make sure that we're paying attention to any contraindications, if applicable, and to make sure that we don't cause further harm to the patient. And these are our references. I want to thank you again for joining us in this topic on mechanical ventilation management.